Hello learners, welcome to lecture number 46. In our last session, we explored the importance of capacity building for community health workers, emphasizing how training and support enhances service delivery at the grassroots levels. Today, we focus on innovative approaches in reproductive and child health service delivery. Innovation is not just by technology, it also involves new ways of organizing, financing, and engaging communities. In this lecture, we will discuss creative strategies from mobile health to public private partnerships that are transforming RCH services in India and across the globe. Innovation in healthcare is about finding smarter, more effective ways to reach those who need services the most. Traditional models of reproductive and child health deliver often fall short in addressing barriers like distance, stigma, or lack of resources. Innovative approaches go beyond clinical interventions to tackle social, economic, and cultural barriers. Whether through digital platforms, new community strategies, or financing reforms, innovation helps achieve equity, quality, and wider reach. Now comes the question why innovation is needed in RCH. What do we need specifically here? We need equity by design delivery models like mobile outreach clinics and informal settlements, migrant led health worker teams, and interoperable records that follow families across geographies. Adolescent friendly innovations should hardwire privacy and consent. Schools, peer platforms, confidential counseling, and stigma aware contraception services. Build climate resilient RCH system. Examples: solar powered cold chains, shaded heat safe facilities, flood or heat early warning protocols, and disaster ready referral plans. Upgrade the ASHA platform or the health worker platform with micro learning, supportive supervision, and periodic OSCE style recertification so competence is demonstrated, not assumed. Deploy privacy preserving digital public goods, multilingual offline capable decision support, defaulter tracking, and two-way referral with client consent and data safeguards. Institutionalize respectful maternity care through bedside checklists, birth companionship, grievance redressal, and MPDSR that triggers time-bound corrective actions. Add pro-financing, transport vouchers, conditional cash for timely postnatal checks, and results-based financing with equity weighings for hard-to-reach blocks. Strengthen last mile supply chains via ELMIS, simple barcoding, and community inventory audits to drive stockouts below 2%. Scale social accountability, community scorecards, public hearings, and citizens facing dashboards so performance gaps are visible and negotiable. Finally, embed rapid cycle learning. Publish disaggregated smart indicators and use NGO government MOUs with backbone coordination to convert pilots into durable right-based national practice. Innovation approaches in RCH can take many forms. They may involve new technologies like mobile apps for maternal health training. They may be new delivery models such as doorstep immunization services or telemedicine consultations. Innovation also includes partnerships and policies that bring different stakeholders together to tackle RCH challenges collectively. Digital tools are transforming RCH service delivery. Mobile apps help track pregnancy, monitor child growth, and guide frontline workers. SMS reminders ensure caregivers do not miss immunization appointments. Online counseling platforms provide confidential advice on reproductive health. These tools enhance communication, improve compliance, and reduce missed opportunities for care. Telemedicine bridges the gap between rural populations and specialized care. Women in remote areas can consult gynecologists or pediatricians without traveling long distances. Community health workers act as facilitators, linking families to doctors through digital platforms. This reduces delays and ensures timely care, especially for high risk pregnancies and sick children. Mobile health units, they extend RCH services to hard to reach communities. Equipped with basic diagnostic tools, vaccines and essential medicines, they provide maternal checkups, child immunization and health education on site. During emergencies, such units ensure continuity of care. Their mobility and flexibility make them crucial in filling service gaps in remote and marginalized areas. Task shifting is an innovative strategy to address shortages of doctors and nurses. Mid-level providers and community workers are trained to deliver basic services like contraceptive counseling, antenatal care or treatment of minor illnesses. This expands access to family planning and maternal services while freeing the specialists to handle more complex cases. Task shifting reconfigures power and practice by formalizing scopes of work, standardizing protocols, and building supportive supervision so quality and rights are protected. Mid-level providers should be trained via competency-based curricula with OSCE-style assessments, credentialing and periodic recertification. Community workers need decision support jobs, aids, and clear referral escalation pathways with two-way feedbacks. Quality assurance hinges on audit and feedback, drug supplies readiness, and respectful care safeguards, especially for adolescents. To avoid de-skilling specialists or overburdening of community health workers, align incentives and duty rosters. Protected learning time and ensure their remuneration and transport or childcare support is made. Equity by design means prioritizing hard to reach areas and disaggregating indicators to surface gaps. Define smart measures to track impact and review them monthly. Finally, anchor task shifting in policy and regulation and in co-production with communities so expanded access translate into trusted, safe and sustainable family planning and maternal and child health services. Public-private partnerships have become vital in RCH. Governments leverage private sector resources such as infrastructure or staff to expand service delivery. Contracting private providers to deliver maternal or child health services improves coverage, particularly in urban slums. Public-private partnerships align government oversight with private efficiency, leading to better reach and quality of services. Community-based innovations have proven powerful in RCH. Women's self-help groups integrate health education with livelihood support, empowering women to demand services. Village health and nutrition committees involve communities in planning and monitoring health services. Community scorecards allow citizens to access health facilities, creating accountability and driving improvements in quality. These platforms activate collective efficacy and shift social norms, turning private concerns into public claims that institutions must answer. Self-help groups function as economic health hybrids, saving credit-reduced opportunity costs for hair seeking, while peer meetings normalize contraception, antenatal, postnatal checks, and early breastfeeding, anchored in respectful, right-based counseling and informed consent. Village health, sanitation, and nutrition committees operationalize co-production and participatory governance by co-writing microplans, tracking budget stockouts, and negotiating fixes for referral and transport. especially for first time mothers, adolescents, and migrants and low caste tribal households. Community scorecards are social accountability tools. Communities co define indicators, rate services safely, and secure time bound commitments from facilities. Community health workers or ASHAs act as boundary spanners, linking these forums to emergency obstetric and neonatal care services, pathways, and ensuring two-way referral feedbacks. Track progress with smart disaggregated indicators reviewed in monthly public huddles. Finally, embed after action reviews and publish simply community dashboards so wins are celebrated, gaps are transparent, and innovations compound into durable improvements across the reproductive and child health continuum. Conditional cash transfer programs such as India's Janani Suraksha Yojana incentivize maternal and child health behaviors. Pregnant women receive cash for attending antenatal visits or delivering in institutions. Families are encouraged to complete immunization schedules for children. These financial incentives reduce barriers and motivate healthier behaviors, particularly among households. Voucher schemes provide subsidized access to private reproductive and child health services. Low income families receive vouchers that can be redeemed for family planning, antenatal care, and safe deliveries. This increases choice and improves access where public facilities are inadequate. Voucher programs also stimulate competition among providers, improving service quality. Community health insurance schemes are innovative ways to reduce financial barriers to RCH services. By pooling community resources, they spread the risk of health costs. Families benefit from financial protection during pregnancy or child illness, reducing catastrophic expenditures. Such schemes enhance trust in health systems and encourage utilization of services. Nutrition innovations are critical in RCH. Integrating ICDS services with maternal health ensures comprehensive care for women and children. School-based nutrition programs address adolescent health and prevent anemia. Community kitchens provide safe nutritional meals for pregnant women and young children, tackling malnutrition while fostering community solidarity. Building on this, treat nutrition as a social determinant. Pair antenatal care with on-site growth monitoring, counseling, iron folic acid supplementation, deworming, and cash or food support so care is feasible for low-income households. Integration means Anganwadi centers and primary health care facilities share schedules, registers, and referrals. Community health workers escort high-risk mothers and children and close the loop with two-way feedbacks. School platforms can deliver weekly iron folic acid midday meals that meet protein and calorie standards. Menstrual health education and stigma-free counseling, raising attendance and delaying early marriage. Community kitchens double as solidarity hubs. Local women group co-govern menus, ensure food safety, and use scorecards to hold providers accountable by protecting dignity and consent. Embed equity by design. Migrant, tribal, and urban slum households prioritized in microplans. Home deliveries during pregnancy, postpartum, and culturally appropriate food. Track smart, disaggregated indicators like more than 80% postnatal nutrition counseling within 48 hours, or more than 90% weekly iron folic acid adherence among adolescents, or more than 10% annual reduction in moderate to severe anemia in priority blocks. Less than 2% of stockout days for supplements and rations, and on-time take-home rations more than 95%. Finally, institutionalize monthly after-action reviews and public dashboards at Anganwadis and schools so communities see progress and co-solve gaps. converting these innovations into durable, right-based gains in maternal and child nutrition. Peer-led models are effective in reproductive health education. Adolescents trained as peer educators engage others in discussions about puberty, contraception, and safe practices. Shared experiences build trust, especially on sensitive issues. Peer models extend the reach of health programs to marginalized groups such as urban youth or tribal communities who may mistrust formal systems. Innovations increasingly focus on engaging men in reproductive and child health. Male champions advocate for maternal health in communities, encouraging shared responsibility. Fathers groups promote children and challenge traditional gender roles. Counseling sessions address myths about masculinity, such as reluctance to use of contraception. These strategies foster gender equality and healthier families. Respectful maternity care is an innovation focused on dignity, training providers to treat women with respect, allowing birth companions during delivery, and addressing mistreatment in facilities make maternity care safer and more humane. These initiatives improve women's trust in health systems and encourage greater use of institutional services. Respectful maternity care reframes childbirth as a right-based encounter rather than a discretionary service, centering autonomy, informed consent, privacy, and non-discrimination, especially for adolescents, low-caste, tribal women, migrants, and the poor. Practical packages pair provider training with bedside checklists, privacy screens, consent scripts, and birth championship as a default, not a privilege. Facilities should institute grievance redressal and link incidents to time-bound corrective actions through maternal and perinatal death surveillance and response, so dignity lapses are treated as patient safety risks. Supportive supervision and audit and feedback replace punitive inspection. Stimulation OSCE stations assess respectful communications, consent for examinations, procedures, and zero separation practices for stable newborns. Community scorecards and public charters make expectations visible and negotiable while protecting anonymity and preventing retaliation. To drive improvement, define smart indicators like percent of births with a chosen companion or percent of consented pelvic examinations or procedures, privacy compliance. Mistreatment reports resolved within 30 days. Client satisfaction disaggregated by caste, class, or age. Pair these with equity by design microplans. Finally, close the loop by reporting results back to communities and celebrating teams that model respectful maternity care. Converting dignity into measurable gains in timely care seeking, institutional births, and postpartum follow ups. Adolescent friendly services are innovative models that address the unique needs of young people. Confidential counseling spaces allow adolescents to seek advice without fear of stigma. School health programs integrate life skills and reproductive health education. Mobile apps provide information discreetly, empowering adolescents to make informed choices about their health. Maternal death surveillance and report is an innovative approach to improving maternal health by systematically identifying and reviewing maternal deaths. Health systems learn what went wrong and how to prevent future cases. Community involvement in reviews ensures accountability and transparency. Using findings to strengthen services creates a cycle of continuous improvement. Artificial intelligence is emerging as a game changer in RCH. AI tools can predict high-risk pregnancies by analyzing medical and social data. Large health data sets are mined to identify patterns in maternal and child mortality. AI also supports decision making by providing evidence based recommendations to providers. While still evolving, AI promises to revolutionize. While still evolving, AI promise to revolutionize RCH service delivery. Implementation science emphasizes equity by design. Models must use disaggregated data and be audited for bias, fairness, and error trade offs, so vulnerable groups are not misclassified or denied care. In practice, AI should be human in the loop. Triage and risk flags for ASHAs and health workers, nurses, not replacements, paired with clear scope of practice, referral pathways, and explainable outputs. For routine care, offline first clinical decision support can guide IMNCI, antenatal protocols, vaccine default tracking, and postpartum danger sign checks on the system side. AI can optimize ELMIS to cut stockouts and route transport to emergencies. Governance is crucial. Data minimization, consent, privacy by default, secure federation where possible, and community oversight committees that approve uses and sanction misuse. Treat algorithms like medicines, specify indications, contraindications, and monitor performance with smart indicators. Couple predictive analytics with MPDSR so insights trigger time bound corrective actions rather than retrospective reports. Finally, invest in capacity. AI literacy for frontline teams, local model fine tuning, and feedback loops that let communities contest errors so the technology amplifies. Social franchising involves creating networks of private providers who deliver standardized reproductive and child health services under a common brand. This ensures consistent quality while expanding access, particularly in areas underserved by public health. Social franchising has been proven effective in family planning and maternal health care in several countries. Innovations increasingly integrate RCH with non-communicable disease services. For example, antenatal visits are used to screen for hypertension or diabetes, addressing the double burden of disease. Counseling on nutrition and physical activity during reproductive health consultations promotes healthier lifestyles. Integration ensures comprehensive care for women and children in the context of rising NCDs. Community media is an innovative way to spread RCH awareness. Street plays and folk theatre communicate messages in relatable formats. Radio and community FM stations reach wide audience, especially in rural areas. Social media campaigns engage youth and urban populations. By blending traditional and modern media, communities can be effectively engaged in RCH education. Innovations often emerge from cross-sectoral collaborations, linking education programs with health-related programs ensures adolescents receive comprehensive knowledge. Livelihood programs improve household incomes, indirectly supporting nutrition. Women's cooperatives partner with health workers to spread awareness. These collaborations recognize the health outcomes are shaped by multiple social and economic factors. Viewed sociologically, this is a co-production across sectors using a collective impact approach. Agree on a common agenda, shared indicators, and backbone team that coordinates without overpowering community voice. Education health links should embed privacy, consent, and stigma-free counseling, pairing school curricula with peer clubs and referral pathways to adolescent-friendly services. Livelihood platforms reduce opportunity costs of care seeking and build collective efficacy, which sustains behaviors like antenatal visits, iron folic acid adherence, and full immunization. Women's cooperatives act as norm entrepreneurs, translating rights into everyday practice through community kitchens, growth monitoring days, and respectful maternity care charters. Governance matters. Sign MOUs on data sharing, safeguarding, and grievance redressal budget for participation so marginalized groups can lead, not just attend. Track smart disaggregated outcomes across sectors and increase in women's saving, regularity, income stability. Use public dashboards and community scorecards to make performance visible and negotiable with time bound corrective actions. Finally, run quarterly after action reviews so schools, cooperatives, health teams, and local governments learn together, turning collaborations into durable, equity focused RCH gains. NGOs continue to be source of innovation. Bangladesh's community midwives improved maternal health access. India's women health collectives advocate for reproductive rights. Adolescent clubs in Africa provide safe spaces for youth to discuss sexuality and health. These NGO led innovations often influence government policies and inspire larger programs. Monitoring and evaluation are critical for assessing innovations. Programs must track their effectiveness, coverage, and quality. Cost effectiveness analysis determines whether innovations are sustainable. Successful models should be scaled up, adapting them to different contexts while retaining their core principles. Without evaluation, even promising innovations may fail to achieve long term impact. Innovations face challenges. Limited resources may prevent full implementation. Resistance to change from providers or communities can slow adoption. There is also a risk that innovations increase inequities if only better off groups can access them. Addressing these challenges requires careful planning, community involvement, and government support. Future innovations will likely focus on scaling digital and AI based tools, bringing predictive and personalized care to reproductive and child health. Greater integration across services will ensure holistic care for women and children. Equity must remain at the center, ensuring innovations reach marginalized populations and do not exacerbate inequalities. To summarize, innovation is essential for advancing reproductive and child health. It takes many forms: digital tools, public private partnerships, community engagement, and cross sectional collaborations. However, sustainability and equity are critical. Innovations must be affordable, scalable, and inclusive to create lasting impact on maternal and child health outcomes. In conclusion, innovative approaches transform reproductive and child health service delivery by making services more accessible, equitable, and responsive to emerging challenges. Whether through technology, community engagement, or policy reforms, innovation ensures health systems remain future ready. As health professionals and policymakers, our task is to nurture innovation while safeguarding inclusivity and justice. So that's all for this session. Thank you so much for your patient learning. Next, we take up lecture number 47, which deals with case studies or successful RCH inventions, analyzing best practices. Thank you.